Good morning, future OT practitioners. I hope everybody is doing okay. Made it through the weekend with hopefully electricity and heat. I know that I've heard from a couple people who are saying that their internet is down, so they're on a hotspot or might not be able to be on the whole session, might get dropped or might not have been able to log on. So I am recording this session. I told y'all that last week that that would be our plan. And I will share the link to that this as soon as I can this afternoon. And so you'll have access to that, or anyone who is not here for the full session will. We are going to kick off things today with our case studies on acquired brain injury. And we're just going to go in the order that you all have your names in that list, with one exception is that our very first person on the list doesn't have good internet service at all. So we're going to delay that one until next week. And we are going to start with Macy.
Okay. Hi guys. Can everybody hear me?
Yes, you're good.
I just want to be sure. Okay, well, I did my case study on Kevin Pierce, who was just 22 years old when he experienced his traumatic brain injury. And all of my information came from his movie called The Crash Reel. And I selected this case study because I wanted to become more familiar with what the therapeutic process could look like in traumatic brain injuries. My brother growing up had a traumatic brain injury that was very different from Kevin's. And so I was just really interested to see like what the therapeutic process could look like and what the differences would be. So Kevin was a very passionate snowboarder who was actually considered a favorite to make the Olympic team, which I thought was really cool. He was known for being incredibly hardworking, and he's also very close with all of his brothers and his friends. And if you've ever seen the movie, you can just tell he's just a really funny, energetic, athletic person. After his accident, all he wanted to do was snowboard again. But he eventually decided that for his safety, he would just snowboard for fun and not competitively anymore. His brain injury impacted his memory, impulsivity, it decreased his independence, vision, and it left him with some depression. But he was able to relearn how to walk and talk, and even snowboard. And he used his accident as an opportunity to counsel with other people experiencing TBIs. And he even speaks to children on the importance of wearing helmets. And you can just tell Kevin just like lights up being able to help people that are in the same position that he was in. And it just gives him like a sense of purpose. And OT in this situation could work on things like medication management, ensuring home safety, or working on increasing independence in ADLs. And he primarily received therapy, acute care, inpatient rehab, and home health. When he was first in the hospital and not showing any signs of being able to talk soon, his brother actually started playing one of his favorite songs, and it got him to mouth the lyrics of the song. And I thought that was really cool because it shows how when you bring something meaningful into the session, like it can drastically increase participation. And his brother also talked about how he quit his job actually to attend therapy sessions with Kevin because he felt like he knew ways to get Kevin to participate more. Like if he turned the activity into a game or a competition, Kevin would always engage more, which I thought was kind of crazy because he was like teaching the therapist to be client-centered kind of. So it definitely reminded me to always think about the client's motivators in the future. And then the last thing I'll share about, and what I thought was super interesting about Kevin's story, is the mental health aspect of traumatic brain injuries. Um, Kevin talked a lot about how his personality did change some, and he even had a friend who would become like dangerously mean with his family members after his accident. And Kevin's was not this severe, but he did bring to light that a lot of people with traumatic brain injuries deal with depression. And he said that a lot of brain injuries are invisible, and so I definitely think that's something that OT should be aware of. And overall, Kevin's story is just super, super cool, and it's awesome to see his family work with him through every step of the journey. There's a part in the movie where he snowboards for the first time again, and it was so, so sweet. So if y'all are bored, snowed in the house, you should definitely watch it. It was really sweet. But that's all I have.
Good recommendation. Thanks, Macy. Maybe we do that later today. It'd be educational too. All right. Next up, Estrella.
I didn't mind on Chris Pratt from the movie The Lookout. He was about 18 when he got in a car accident and had a traumatic brain injury. I selected this specific one because I feel like a brain injury is something that could happen to anybody at any time. So I feel like it's important to kind of know what to look for and how to navigate life after something like that happens. And then I got the majority of my information from the movie The Lookout, and then of course just like the slides from class. I would say his like occupation before his injury was like just being a student and playing hockey, but after, which is like about around when he's 21, which is the majority of the movie takes place around that age. I would say his priorities were just like where his occupations were. He was like a cleaner at a bank, and then he took student classes at for a life skills class, kind of help him navigate life again. So, but his priorities, I would say, or what he wanted to get back to doing was kind of being able to be more social. So he kind of had trouble talking to people or just introducing himself or even just having making new friends because now that he's not talking to his friends in high school anymore, he kind of has issues with that. I would say the role of OT or like the OT process would be more so a purposeful activity. So like going out into public and kind of giving him uh opportunities to kind of practice talking to people or even just like especially girls because that's his main goal is to talk to girls or find a girlfriend. So him having like a lack of impulse control really hurts him in that department. So things that could help him get back to that. And then also like a home health setting just for safety because he does have issues like hurting himself with cooking. So teaching him how to do that and navigate that safely. Compared to what I already knew, I would say that this was pretty on par, but I think the most surprising thing was just how much that this could change your personality because before his injury, like he was like really popular. He's a ladies' man, like but now he's scared to even say hi to a girl or talk to anybody. So that's a really drastic change, especially something for him to get over from being able to have all these friends and all these girls to not even being able to have anybody to talk to. So I think that that was uh, the most surprising thing to me about his personality, how that changed. And I would say the biggest takeaway was just how to be kind of aware of how this can happen to anybody and just knowing how to navigate that is really important. And that you should be patient with people who go through this because they don't know how to navigate it just like you don't. So y'all can kind of learn together.
Very good. Lots of good takeaways for that one, too. Thank you. And next up is going to be Catherine.
Can y'all hear me? Okay.
Yes. Yep,
Okay.
you're good.
I chose to do my case study on Tina Ball. Some of you may have heard of the Ball family. Tina, her husband, and her three sons are all very well known in the basketball world. So you might have heard of them. I actually chose to do her for my story because I had seen her story shared on social media several times before. So I immediately came to my mind when I was picking my case study. I was especially drawn to how open she shared her experience with aphasia and how she emphasized the importance of the person behind the diagnosis. So, Tina experienced a major stroke at the age of 49. Following her stroke, she developed expressive aphasia, meaning she knows what she wants to say but has difficulty producing speech. She also experienced right-sided weakness, and so now she moves around using a cane. However, the exact medical subtype of her stroke isn't publicly documented, but she has shared many of the functional impacts that her stroke has had online. So I used three sources: the National Aphasia Association, and then a video interview and a Washington Post article. So, what really stood out to me was that her priorities weren't just about regaining her speech, they were more about being understood, staying connected, maintaining independence, and continuing meaningful roles, including being a mother, a wife, but particularly her role as an advocate for people with aphasia and increasing public awareness of aphasia. Another thing that really stood out to me was the strong impact that her family had on her recovery. There were many videos of her mom and her husband getting super involved in her therapy sessions. They practiced communication strategies with her and encouraged her as she regained her strength. Her expressive aphasia significantly affected her social participation, self advocacy, and efficiency in daily communication. However, her comprehension was still largely intact, but because conversations took more time and energy, that often led to fatigue and frustration. And then also her right sided weakness added mobility and safety components, influencing how she navigates through her daily routines. So, in a case like this, OT's role is not necessarily to treat speech directly, but to support participation in meaningful occupations. So, an OT would work closely with a speech language pathologist while focusing on functional communication during real life activities, energy conservation and pacing, communication, training, and education, especially for family members and friends. And then obviously supporting safe mobility during daily routines, including ADLs and IADLs. So the OT process would most likely take place in an outpatient neuro rehab or community based setting. Evaluation would focus on communication during daily tasks, cognitive communication skills like attention and processing speed, and then balance and safety. Intervention would likely use an establish/restore approach with an emphasis on compensatory strategies in real life practice. So, really, my biggest takeaway from this case study is that aphasia really impacts more than just communication. Especially for Tina, it impacted her identity, confidence, and participation. So I really feel like Tina's story reinforced how important OT is in supporting meaningful roles and increasing quality of life rather than focusing solely on the deficit of the client, which is obviously in line with our holistic top down approach that we've learned. That's all.
Very good. Very good. Thanks for sharing. I appreciate that you pulled from multiple resources for that because sometimes, that's a hard thing when you're choosing somebody that, whether they're like a fictional character or a real person, you don't personally know them. So you sometimes have to dig for that information. But it all is part of that, putting it together. Good job. Thank you. Mariella.
Hello. Um, so my person is Pritchard Collin. Pritchard Collin was a pro boxer. He's currently 33 years old, but when he suffered from a traumatic brain injury, he was just 23 years old. Um, to be more specific, he suffered from a subdural hematoma, um, and he required an emergent hemocranectomy. I don't know if I'm pronouncing it right, to relieve pressure and to just evacuate the blood from his brain. Um, for the sources I used for this, I chose this person because I've heard about him a few years ago, and he's just, I don't know, that case just really remained memorable to me. And when I was trying to look for someone to talk about, he popped up on my feed again. So I was like, wow, this is a perfect person to talk about. The sources I pulled were from Brooks Rehabilitation website, ESPN mini documentary, and then I also was able to access the legal documentation of the lawsuit against Dr. Ashby, which was the doctor that was on site the day of the fight. Um, Pritchard was, as I said earlier, a former professional boxer. He was a huge public figure, especially for his Puerto Rican audience, and he was a son and brother. Some challenges and barriers he faced was right after his surgery, he was in an unresponsive wakefulness state for over a year, meaning that he could just breathe and sleep. And he uses a feeding tube. He also, since the left side of his brain he's affected, he experienced like right side weakness and paralysis. He also had impaired speech, cognition, and motor control, and he's unable to perform like any ADOs or IADOs. As an OT, they can train and educate the caregiver on just like transferring, assist on like assistive devices such as like using his motorized wheelchair or um, things like that. Also, I was reading through the Brooks Rehabilitation website, and the OT, he didn't receive OT until 2018. So his accident happened in 2015, but he didn't receive OT services until 2018. But what they would do with him was they worked on like his motor impairment, so they would use deltoid swings and also splints. Um, and yeah, I think that's it. Hold on. OT settings that Pritchard was seen in following his surgery, he was in acute care and inpatient rehab. Currently, with Brooks Rehabilitation Center, he's currently receiving outpatient rehab, but I think he would really benefit from home-based OT, especially since his mom is his main caregiver. So just receiving services there, I think he would really benefit from that. And yeah.
Good information. Thank you. Very good. And some of what you said is going to really relate really nicely to what we're going to talk about today. So it's almost like we planned it. And next is Grace.
Okay. Can y'all hear me pretty good?
Yes, you're good.
Okay. So I chose the movie, I chose Henry Turner, and he is in the movie regarding Henry. And I chose this because I just wanted to learn more about traumatic brain injury outside of like the class aspect. So, a little backstory about this movie. Henry Turner he was a husband, father, son, and a lawyer who he was kind of like self-centered, and he took like his job way more seriously, and he really didn't have an emotional connection with his family or his friends. He mainly just focused on work, and that's it. And that's how his parents made him act. And then he was shot in the head in his frontal lobe, and that caused him to go in the hospital and have all the tests done. And they found out that he had a traumatic brain injury, and he was unable to speak, do fine motor, gross motor, anything. Like he was just laying there. Then after a while, he was able to get up, and I thought it was cool because I really didn't know that PT and OT had such a like great like OT and PT do so much for people that have traumatic brain injuries because they like within the first 30 minutes OT was over there like, oh, push like where's the circle, where's the triangle, and he would do it, but it was slow. And then the PT came in, and he was pushing him more, and he was like, okay, well, since you can't speak, I thought it was funny because he was like, oh, well, since you can't speak, I'm gonna give you like hot sauce on your eggs, and that made him speak. So I thought that was cool how he kind of forced it. Um, but that's just a little backstory. His personal interests would be his family. Um, After a while, he was able to regain his strength and some speech, but he still couldn't read. So his daughter, which he really didn't have a great connection with before the injury, his daughter helped him read again and relearn his like childlike personality. And um, I would say that two settings that he could receive OT was inpatient rehab, which is what the OT and PT did to help him, and home health, because whenever he went home, he had a hard time figuring out where stuff was, even though the maid kind of helped him, but she was still confused of why he was acting like that because nobody really told her. Um, Reading, cooking, because he really didn't know how to read, so his daughter was helping him. Um, I would say that he improved his fine motor, upper extremity strength, and his self-care while in home health because he really didn't remember how to do anything. And any precautions, I would say, or like safety concerns, mobility rehab, speech therapy. Um, he would need somebody to supervise his daily living just in case something were to happen. And um, just to manage his impulsive behaviors. And mm, I think overall he just had a hard time relearning new stuff. Well, not new stuff to him because his wife really didn't know how to help him since she's never had anybody in her family like this. So I think just having an OT there at like being with for home health would help him get better. So yeah.
Thanks, Grace. Good job. That's a good movie too, if y'all haven't seen that. All right, so let's see. Oh, okay, let's talk about Respond Us and the plan for Wednesday. So keep in mind this is all contingent. My prediction, my very layperson prediction is we probably will not be back on campus by Wednesday, but that is not official. And we all just have to watch for the announcement like we did yesterday. And I don't know if they're probably just going to do it day by day. So we may not even know till, tomorrow afternoon. But we will have the exam on Wednesday at our usual time. If you are on the same computer, you haven't, cleared out your whole system and done a hard reset since you had biomechanics, you have Respondus already downloaded as you will need it. If you have something new or you've done something wild like resetting your whole thing, you will need to download it. So what I did just to make sure we are all good with that is, let me share my screen. I made a little pretend, um, little test, little pretend test. So if you will get on the course site and go under, and you can do this now or later, under exams and quizzes, and then under exams, you're going to see one that says testing for remote, like a practice for the remote exam. This is in case. Well, you'll need Respondus even if we're in the class. So for this one, let's see. Let me actually put my Blackboard in student view so it'll look, if I can shrink this Zoom a little bit for a second, it'll look like you all see it on your end. All right, here it is. So under exams and quizzes, exams, and then you see the testing one. That's the practice one. So if you click on that and then you start it, it's going to ask you a couple of questions. But before you do that, notice this right here, the assessment security, saying you would download it here if you don't already have it installed. If you're not sure, you can just do it again and follow the steps there. So before class on Wednesday, whether we're going to be in person or not, everybody needs to have done that. So, if you're unable to do that, you won't be able to access the exam because we will, regardless of whether we're in person or on Zoom, we will be using Respondus. Um, if we do take it from, not on campus, you will have to have your Zoom camera on the whole time. If you have a special circumstance that won't allow you to do that, please talk to me ahead of time. So if you have questions about any of that, we're going to be adaptable and play it by ear. But that's one thing that you can do in advance, and you'll need to do it just to make sure you have responders, so you can test it with that little practice thing under the exam folder. just to make sure. All right. So now I want to ask if anybody has a takeaway, anything you wanted to share about the prep work. So I put links for the Brain Injury Association website, and there's a bunch of little videos there you can see about real life, people's real lives. And then also there was the coma one, which is really from an HBO series that was years ago, but they've put it on, I guess, YouTube now, so anybody can watch it. Any takeaways from that? Anybody wants to share either out loud or in the chat? No, no takers. All right. Well, if you did not watch those, especially the coma one, please do. It's really hard to fully explain what a coma looks like, and we're going to talk about it today, the kind of textbook version of that. But watching that, and it's just 15 minutes, and then I think there's one or two others of that are also 15 minutes. But if you could just watch the first one, it's stories. It's a documentary about people with traumatic brain injury who have or are in a coma. So it'll really help your understanding of what we're talking about today and really kind of overall about acquired brain injuries. All right, before we start with today's lecture, I'd like to ask you, if you are in a place where you can get to the chat, if you would put, and don't do it yet. Don't wait till I say, you can go ahead and type it, but don't enter it until I say go, and then we're gonna kind of waterfall, so everybody will be doing it at the same time. One specific thing that the slums asks a person to do. It's a little retrieval practice. You might see a question like this again. Okay, everybody enter it in. Good, good, good. All right. So good retrieval. So you might see something like that again, and it should come right to mind because you just did it, and actually doing a hands-on thing should help you understand that or remember it. All right. So I'm now going to share my screen again, and we're going to get into the material for today. So this is a continuation on the slide deck that you all have had for this whole, whatever, like 5 sessions. And all right, can you all see my screen? Yes. All right. Okay. Thanks, Laura Beth. Just making sure I don't start going and no one tells me that you can't see what I want y'all to see. And you have these slides too. So let's talk about the classification of traumatic brain injuries. Remember, well, a little bit of review. Remember the two age groups that we see traumatic brain injuries most often in are, well, really three: young children, preschoolers, toddlers, just learning their motor skills, teenagers, and then older adults. And those are related to different reasons: falls or impulse control, being steady on your feet, that sort of thing. Um, when someone does have a traumatic brain injury, when they first come into the emergency department or, even in acute care, or the ICU, the medical team is really looking at classifying that traumatic brain injury because even pretty early on, it gives a fairly early prediction of what things might look like in that person's future. Every case is unique, of course, and there are going to be some people that don't fall under the pattern or the prediction that the team sees, but it's important for us to know what that pattern might look like based on the different classifications and even what those classifications are. So if you see on the slide, we really talk about traumatic brain injuries in terms of mild, moderate, and severe. So I wanted to map out for you what indicates that someone would be in which of those categories. So the first thing we look at is loss of consciousness. Now, this is immediately after the brain injury. So if they're in a car accident, if they're hit by something. And so that loss of consciousness is sometimes abbreviated in a medical chart, LOC. So if you see that, that's what it means. If they do not lose consciousness at all, or if they do, but within a half hour or so, they're back, alert and at least fairly oriented, that would be an indicator of a milder traumatic brain injury. Now, if the loss of consciousness lasts up to 24 hours, that's moderate. If it lasts longer than that, we're probably looking at what's going to be classified as severe. The next indicator that the team looks at is um, the person's ability to remember from before the injury. Now, it's pretty common, actually, really common, that someone who has sustained a traumatic brain injury doesn't remember the actual minutes right around the injury. And, it's said that that's a protective response that our nervous system, keeps us from remembering the worst of that. But from before, like what happened a week or a month or a year before, this kind of relates to that regarding Henry, I feel like. So that's referred to as post-traumatic amnesia. So if they're unable to remember from, you know, a, a day or so, that's mild. If it's a week or more that or right at a week to one day that they don't really remember what happened, that is indicating a moderate, and severe is if they don't remember from before 1 week. And the last one is one of the rating scales, one of the assessments that we're going to study in relationship to TBI, which we're about to talk about. This one is a really, really commonly used one, and it is called the Glasgow Coma Scale. And it's more often just referred to as the GCS. And if you are a medical drama watcher like Grey's Anatomy or any of those that are going that are on, you'll often hear them say this person has a GCS of 7 or 10 or whatever it is. So we're going to talk about now what that actually means. So here is a screenshot of the GCS, what this scale really is. It's supposed to be a quick and pretty direct rating system. Now, usually it will not be an OT that's doing this, but the relevance to you is that if you are working with somebody with a brain injury, you will see in their chart upon admission, their GCS was whatever. And then, a day later, a week later, what was it? And so you would need to know roughly what that means. Now, important to note that the lower scoring is worse means that they are more severely impacted. The higher score means that they are not as severely impacted there. Overall, the GCS is a test used to monitor consciousness. It does look at, as you can see by the categories on right there on the screen, it looks at motor, verbal, and eye-opening responses. So it's looking to see how the person or whether or not they respond to different types of input in different ways. It's an objective way to measure the alertness or the conscious state of a person. Now, looking at that, at this scale, think for just a second, and then I want you to put in the chat, what is the absolute lowest that someone would score on this? That would indicate deep unconsciousness. And when you're ready, put that number in the chat. The lowest somebody would make on this. All right, thanks for responding. So this is one of those things where I think if you guess or put what you think you see and then we talk about it, you'll remember it more than if I just say it. So notice here on the screenshot of the scale, there are three categories, right? There's eye-opening, motor response, and verbal response. So in other words, do they open their eyes spontaneously, or if someone starts an IV or moves them and it might be uncomfortable for them because they have injuries, do they open their eyes at all? So the lowest score they could get in that category is a 1 if they do not open eyes in response to any stimulation. So even if something's really loud or it's really painful or people are asking them to do it, they're not doing it. So they're going to get a 1. The next one is motor response. So that can be just like you and I would. If someone asks you to do something, you're going to follow the command. That's a 6 in that category. If they do not respond from a movement standpoint, even in response to noxious or painful stimuli. So in other words, if someone pokes them with something, they don't try to withdraw um, or fight back, then they're going to get a 1 also in that category. So far we have a 2. Then the last category is verbal response, and that there's some orientation. So they might get asked questions. And if they don't make any response to questions, or if they're upset, they're not vocalizing, they're not crying with a vocal sound, they're also going to get a 1. So if you look at that, if they the lowest they're going to get on this scale is a 3, because that would be a 1 in each of those three categories. So hopefully you see how that works. I'm going to show you this video. I think is like 8 minutes long, so we may not watch the whole thing, but I wanted to watch it together just because it relates to this actual testing.
The Glasgow Coma Scale is a useful neurological scale used by nurses and medical professionals alike. It is helpful in giving a reliable, objective way of assessing a person's level of consciousness after a brain injury. This standardized scale is useful in predicting survival, but a score is only as good as the person assessing it. The problem is, it's confusing. That's why we've created this helpful, funny guide to help you remember the Glasgow Coma Scale. Contrary to what you might think, the Glasgow Coma Scale was not named after a man named Mr. Glasgow, but after the University of Glasgow's Institute of Neurological Sciences, where professors of neurosurgery Graham T. Sale and Brian Jennett published it in 1974. So why is it important? It's highly predictive of mortality. The Glasgow Coma Scale, GCS for short, is broken into 3 parts that each get a score. Eye-opening, which gets a score from 1 to 4. Verbal, which gets a score from 1 to 5. And motor, or movement, which gets a score from 1 to 6. Let's begin with eye-opening scoring. Scoring a 4 for eye-opening means patients open their eyes spontaneously. Look at that cutie.
So this could be a way that I'm going to go ahead and
Scoring is
I'm going to go ahead and stop that so we can use our time. But you can see that link. And you can Google on YouTube or anywhere like ways to remember or understand the Glasgow Coma Scale. And same with like cranial nerves and neurotransmitters, and that might be something that helps you in learning about that. So questions that might be asked, things that you would need to know about this is, what does it measure? And what does a low score indicate? What does a high score indicate? And then make note of at the lowest score or towards the bottom of that scale, what functionally would we expect that person to be doing at that point? In the middle of that scale, what might they be doing? And at the very highest, what might they be doing? So those really 3 or 4 pieces of information, if you make note about that, that will really help you clinically. All right. Oh no. Well, hopefully you guys can see, and I did post a picture of the JFK coma recovery scale that you should be able to see, or you can see I actually posted the document. Um, it is sometimes called, this confused me at first because I was looking for the letters JFK, and sometimes this one is called the JFK CRS or CRSR, just meaning coma recovery scale. And it, like the Glasgow, it also looks for level of consciousness, like we're going to talk about what those different levels are. It looks at subtle behaviors to differentiate and monitor recovery. And um, it's more detailed and some would say more even reliable than the Glasgow. So it's becoming more and more used or documented. So you might see both of these used. I so far haven't heard this JFK CRS mentioned on any TV shows, but maybe it will be. All right, let's watch a little video on this one.
I'm not afraid. This is how we do it. The Coma Recovery Scale for Accelerated Standardized Testing, also known as CRSR FAST, was recently developed to detect conscious awareness in patients with severe traumatic brain injury in the ICU, with a sensitivity of 81% and specificity of 89% of detecting consciousness. It is feasible, valid, and reliable when compared to the more extensive CRS Revised scale. This test takes an average 6.5 minutes to complete and facilitates serial assessments of consciousness. Prior to the exam, review the medical record or speak with the clinical team to determine whether confounding issues may affect the examination. Record administration of psychoactive medications. When possible, administer the exam when sedation has been lifted. If this is not possible, list the psychoactive medications on the case report form. Observe and record spontaneous behaviors for 1 minute. If the eyes are closed or there are other signs of under-arousal, administer the arousal facilitation protocol. The goal of this intervention is to prolong the length of time the patient maintains arousal. The protocol is administered anytime the eyes close or there is no response to verbal or tactile stimuli. Present deep pressure stimulation unilaterally to the face, neck, and shoulder. The muscle should be firmly grasped at its base between the thumb and the forefinger. While squeezing the muscle firmly, it should be rolled back and forth through the fingertips 3 to 4 times. Repeat on the contralateral side. This is a copy of the record form. Adhere to instructions for administration of items and present each one in the order listed on the form. The response window for each stimulus is 10 seconds, and only score clearly discernible responses. Item number 1, reproducible movement to command. Select at least 2 commands, eye movement, limb movement, or oral commands, and present each over 4 trials at 10-second intervals. The same command should be used for all 4 trials of each type of command. Now, look. Pick out your tongue. Repeat 4 trials of each command. A scoreable response is when at least 3 clearly discernible and accurate responses occur over 4 trials of either type of command. Our patient scored a 0 for reproducible command following. Item 2, fixation and visual pursuit. Fixate your gaze on the mirror image. scorable response for visual pursuit is when the eyes follow the mirror for 45 degrees without loss of fixation on 2 occasions. A scorable response for visual fixation is when the eyes change from initial fixation point and refixate on the new location for at least 2 seconds. At least 2 episodes of fixation are required. Our patient scored 0 for fixation and visual pursuit. Item 3, automatic motor response. Automatic motor behaviors are complex, overlearned movement sequences that occur in response to specific environmental triggers and cannot be attributed to reflexive activity, such as the grasp reflex. Examples include nose scratching, grasping the bed rail, pulling indwelling tubes and lines, and picking up objects. Observe for episodes of automatic motor behavior that occur spontaneously during the examination. A scorable response is when at least 2 episodes of automatic motor behavior are observed during the examination, and each episode can be clearly differentiated from a reflexive response. Our patient scored 1 for automatic motor response. Item 4, localization to noxious stimuli. A scorable response is when the non-stimulated limb locates and makes contact with the stimulated body part or source of stimulation on at least 2 of the 4 trials. This may also be scored from the arousal facilitation protocol. Our patient scored 1 for localization to noxious stimulation. Item 5, intelligible expression.
Ma'am, I would like to hear your voice. The opposite of up is what?
Music.
The color of grass is what?
Those 2 verbal prompts should be repeated twice each. A scorable response is when each of the following criteria are met. First, each verbalization must consist of at least 1 consonant, vowel, consonant triad. For example, ma would not be acceptable, but mom would. Second, 2 different words must be documented by the examiner to ensure that a repetitive word-like sound is not mistaken for a word. Words need not to be appropriate or accurate for the context, but must be fully intelligible. And third, words produced by mouthing, writing, or alphabet board are acceptable as long as they meet the scoring criteria. Verbalizations that occur spontaneously or at other times during the assessment and meet these criteria should also be scored. Our patient scored 0 for intelligible expression. These 5 core items are administered in order until a scorable response is elicited or observed to occur spontaneously and meet the scoring criteria. The final rating is conscious if at least 1 of the core items is observed, or not conscious if none of these items are observed. Our patient appears to be in a minimally conscious state. There are 3 supplementary items, 2 of which can be used by the examiner to detect emergence from the minimally conscious state. Supplementary
All right, so let's
items.
Let me figure that out. Let's stop there. So think about in your head, and then I'll tell you the answer, but just so you're retrieving, what is measured by the GCS, by the Glasgow? So I want you to think about, in general terms, what it measures, and then there are 3 specific categories that are measured by that assessment tool. All right, so let's go back and look. So it measures consciousness. And the 3 categories are eye-opening, motor response, and verbal response. Now, on the Glasgow, the lowest is a 3, and that's going to indicate coma, very, very minimally or non-responsiveness. The middle score for that, when somebody would be considered emerged from a coma, but still having some cognitive impact, is like a 9 to 12 on the GCS, and the highest is a 12. So if somebody got all the points I mean, the highest is a 15. So if somebody got all the points, they would get 4, 6, and 5. So that's the GCS. Now, in contrast, the CRS or the JFK CRS, the highest score on that is a 23. 10 or more means that they do have a conscious response. So that's kind of what it was indicating in that simulation video. Now that one can go all the way down to a 0. And it also measures consciousness according to how someone responds or whether or not they respond to different requests and stimuli. The GCS is by far the most widely used measurement of consciousness. But the CRS is considered more detailed and some would say more reliable. All right, so talking about coma, when someone is, whether or not, let me see if that's a question. The highest score for the JFK is a 23. So that one goes from 0 to 23, whereas the GCS goes from 3 to 15. That's one reason I think that people are saying it's more detailed, is there more levels that you could say between 0 and 23 and 3 and 15. So when someone comes in and they have had a traumatic brain injury, when they are having a decreased level of consciousness, so they might be comatose or slightly above that in their level, you will often see one of two atypical or abnormal postures in the person. And so posture is thought of as the way somebody holds their body involuntarily. And it gives us an indicator of what's going on in the brain just at a glance. Um, it also, from an OT standpoint, tells us what we might need to do early on in intervention. And somebody may even not emerge from this state. And so it might mean long-term care management in terms of physical needs of the person. So the two most basic abnormal postures are shown here on the screen. They are called decerebrate and decorticate postures. So I'm going to tell you how I remember that, and then hopefully that will help you. You might see these images or descriptions. Again, these would be very important for you to know, regardless of what age client you work with. Certainly, if you are working in a nursing home or inpatient hospital or maybe even long-term rehab, this would be important for you to know. Now, sometimes when someone comes in with an abnormal posture, they will get better and they will regain movement, voluntary movement, and be able to posture in a more typical way when they're lying down. Sometimes it doesn't. So let's talk about the two different most basic abnormal postures. The one here at the top is called decerebrate, and it results from damage to the upper brain stem. Notice the posturing, especially of the limbs of this person. The arms are drawn in or adducted and extended. Even the wrists are pronated and hyper flexed. The legs are often very extended and including plantar flexion of the feet. So full, really extension all the way down. Now, the flip side of that is decorticate, which you see in the bottom image. That one results from damage to a different area of the brain, and in this posture, the arms are drawn in, so adducted and flexed. The legs are also extended but internally rotated. So more kind of drawn in. So here's how a lot of people remember these two. If you look at the word decerebrate, it has a lot of several E's in it. So we think of the term extension. So decerebrate is extension. Decorticate, we are going to focus on the word core. And in this one, the arms at least and somewhat the lower extremities are drawn into the core. So decorticate is more a flexion posture and decerebrate is more an extension posture. So that's how a lot of people remember it. Decorticate is sometimes referred to as the mummy pose. And what it means is there's fairly substantial damage to the brain. And that, people will sometimes say the person looks like a mummy. Decorticate posture is considered more severe. It often relates to damage to the thalamus and other areas of the brain, like the midbrain and the cerebral hemispheres. Decerebrate, so the front one, again, related to extension, is sometimes called decerebrate rigidity. You may occasionally even see the person's jaw clenched, but they're very, very extended and tight. And sorry, this is considered even worse than decorticate, a predictor of a more severe brain injury because it relates to the brain stem. So both are indicators of a severe disorder of consciousness from a traumatic brain injury. Very concerning, but the decerebrate is considered more so because it relates to the brainstem, which, as you know, controls basic bodily functions. All right, so let's take a 5-minute break, stand up, stretch, get something to drink, and we will start back at right at, well, 1 after 11, and we'll talk about the Rancho Los Amigos, another type of scale that is often used in regards to traumatic brain injury. All right, welcome back for the second half of this session on the wrap up of traumatic brain injury. So, I want to introduce you to two things here. One is the next scale we're going to talk about. This one is very, very commonly used and referenced in traumatic brain injury work in rehab. It is commonly referred to as the Rancho. But the full name you can see here, the Rancho Los Amigos scale. The Rancho Los Amigos is actually a rehab facility, and they developed this scale. It also looks at level of consciousness in addition to cognition. And what's unique about this one is it is organized in what would be considered the typical progression or sequence of progression of recovery after a TBI. So often, right after someone has a TBI, they will be functioning at level one, or two or three. That's the kind of the opening. And then over time, depending on the individual, they will hopefully progress through the different levels, going up to level 10, which is purposeful, appropriate with modified independence. And we'll talk about what that means in just a second. So this one measures consciousness and cognition, as well as the expected level of progression of recovery. Now, important to note that not all people go through all the way back up to level 10. They may plateau somewhere, and that may be their long-term status. But this one goes from level 1 to 10, and you can see what that means. And I want you to kind of group those levels together when you think about what is indicated. And so to help you do that, the second thing I'm going to introduce you to is an OT who happens to be a friend of mine. She's pretty widely known in the OT circuit, especially on social media, and she goes by the name OT Miri. She lives in California, and her story is that when she graduated from OT school, she had to take the board certification exam more than once. And after she found out that she did not pass it the first time, she felt like she was very alone in that, and had a hard time kind of getting her feet back under her and taking it again. And she pledged when she was preparing to take it the second time that if she passed it, she would create a support system and resources for others that had gone through something similar. And she actually did. And so she is on Instagram. I think she's probably on Facebook, but she now, over the past few years, has even developed her own website where she houses a lot of her videos or links to her YouTube channel. And so that's otmiri.com, Miri. And I'm going to show you the one that she has done on the Rancho Los Amigos.
Having you be my mentor has been life-changing. That's why I was like, do this, start your private practice.
Hi guys, my name is Miri, and today I'm going to talk to you about the Rancho levels of cognitive functioning. Now, this is for OTs and future OTs who are diligently studying for their NBCOT exam. And if you're here, it's probably because you are trying to either learn the material, having difficulty memorizing this stuff, or you find this simply overwhelming and daunting as I did. So the purpose of this video is not to necessarily go over every single bullet line item, because you can do that using your Pedretti occupational therapy textbook, as I will be referencing today, but to give you some study strategies that I thought was helpful in helping to understand each level broadly. So first, what I'm going to do is go over the categories that I lump these levels in, and then after that, I'll break down each level with a little bit more detail. All right, so the first category, levels 1 through 3. I like to lump these categories together because the common theme here is that the patients require total assistance. So when you're thinking of a patient that requires total assistance, what comes to mind? You may see a patient in bed with very little motor movement, if at all, significantly delayed response to any commands or stimulus, if at all. And so levels 1 through 3 requires total assist. Now, the next category, levels 4, 5, and 6. The common theme here is that the patient is confused. Okay, so at these levels, what might you expect? Learning? Probably not. And if so, with lots of assistance. Will they have purposeful or goal-directed behavior? No, their attention will be pretty divided, fleeting, and non-specific. All right, so that's what you have for levels 4, 5, and 6. Common theme, confused. Levels 7 and 8, they're pretty high functioning. They're either at automatic or purposeful level. And so this is at level, this is the category at which the patient is able to have new learning, correct and modify their action or behavior with assistance. And for the purpose of this video, I'm just going to go through levels 1 through 8. 9 and 10 are pretty similar to 8. I'll leave that up to you guys to study on your own, okay? All right, so going back to the levels, let's put some more details to these levels. Level 1, no response, total assist. They will appear asleep, like Stella. Okay, so no response to sound, hearing, touch, pain, nothing. Okay, level 2 is where we have generalized response at total assist. So what might you expect? They may have a gross reflex motor response to pain, but their response will pretty much be the same regardless of the type and location of the stimulus. It's not until you get to level 3 where you will have a localized response at total assistance. So localized response, they may turn to or away from painful or auditory stimulation. They may blink when light passes through their visual field. They might even be able to follow and track moving object. So they are responding directly to the stimulus. Localized response at level 3. So levels 1 to 3, total assistance. And this is when they are having pretty low cognitive and physical functioning. Now we get to level 4. 4 through 6 is where the patients are confused. So 4 is confused and agitated, requiring maximum assistance. So for level 4, what I like to do is put myself in the situation. You're alert and in a heightened state. You don't know where you are or why you're there. You're confused. You don't really know what time it is. You don't recognize the people coming in and out, offering you help. How would you feel? I would feel agitated. So what might you expect at this level? You may see the patient trying to crawl out of bed, trying to remove or pull off their constraints. They may appear moody, aggressive with flight behavior. They may be happy one moment, upset the next, very little short attention. So treatment at this level, probably difficult. They will be unable to cooperate with treatment planning at this level. All right, level 5. They're confused, but at this level, they're no longer agitated, but inappropriate. So level 5 is confused, inappropriate, requiring maximum assistance. So inappropriate, what does that look like? You may see a patient wandering about, not really knowing where he or she's going, with a vague intention of going home. What's another example of inappropriate? Inappropriate use of objects. So you give them a toothbrush, instead of brushing their teeth, they may try to brush their hair. So these are some of the examples of inappropriate behavior. At this level, the patient is able to perform highly familiar tasks with enough structure and cues provided. Moving on to level 6, this is where the patient is confused, but no longer inappropriate. So this level is confused and appropriate with moderate assistance.
Yes, this is why I switched to injectable.
All right.
I was eating healthy, working out every day, and Nothing would budge. I've lost.
All right, so for patients at level six, I like to sort of think of it as with 2 points, and that is awareness and attention. So at level 4 and 5, their attention was very brief, infrequent, and they weren't able to really attend for a long time. But by the time they get to level 6, they can attend to a highly familiar task for up to 30 minutes. So this is a big change here. Also, there is a vague recognition and emerging awareness of the self and others. So again, this is different at level 6. You have some sort of awareness. So that's level 6. They're confused and appropriate, requiring moderate assistance. All right, that was a lot, but I hope this is sort of helping you guys break down the information. Okay, level 7. This is an important one. This is automatic and appropriate, and they require minimal assistance. The reason why 7 is so big is because new learning occurs here with minimal supervision. And so at level 7, they have attention. They can attend to a familiar task for 30 minutes, and they can monitor accuracy and modify tasks with minimal assistance. The only thing here is that they may be unrealistic in planning for their future. They're not really aware of how other people feel, and they may not really be aware of appropriate social behavior. So level 7 is a big one. I think the big one to remember here is that there is new learning with carryover that happens. Finally, we're at level 8. This is purposeful and appropriate, and this only requires standby assistance. So patients at this level, they're able to attend to and complete a task for up to an hour in even a distracting environment. And so pretty independent, and this is where they can use assistive memory devices like to-do lists to help them remember and perform independently. So there you have it, levels 1 through 8 on the Rancho levels of cognitive functioning. I hope this helped you. Good luck studying, and that's it.
All right. So now you know that OT Mary has some different resources, a lot of videos she's made to help people understand and remember things like that. She didn't go over the last 2 levels just because they're higher level, and the person may even be discharged or going home at that level. All right, let's talk about severe disorders of consciousness. What we've been talking about kind of led up to this. And this relates to the video that I asked you all to watch for prep work, the coma, which again it's a YouTube video, lasts about 15 minutes from a documentary that was on HBO. Coma is a state of deep unconsciousness that lasts for a prolonged or indefinite period of time that has been caused by severe injury or illness impacting the brain. And it impacts or negatively affects the person's sleep-wake cycles and loss of capacity to interact with the environment and things in the environment. And according to the Rancho, you can think about those lower levels being comatose, not opening their eyes spontaneously, even with stimulation, not following commands, that sort of thing. Now, the next step up from being considered or classified as comatose is called a vegetative state. That's not the most user-friendly terminology, but it is one that still exists out there, and you will see it if you work with people with TBI. A vegetative state is one that the person has complete unawareness of their self or the environment. A big difference here, though, is that if they're doing an EEG on them, they can tell that they have cyclical patterns of sleeping and waking and some periodic eye opening. But no purposeful movement or response to other types of stimuli. Now, the next one up, moving towards full consciousness, is called minimally conscious state. And this one, as you might guess by the title, means that the person has some conscious awareness. So, in other words, they're demonstrating some behaviors that can be observed that show that they have an awareness of themselves or the environment, even to a small degree. So, this is the measurement for this is that they more than once follow a simple command, may nod their head yes or no, or point or reach out for somebody. They may speak in a way that the word or phrase can be understood, even if it doesn't make sense. They may, as Mary said, reach for an object or a person. They may cry appropriately in response to either emotional conversation or pain. They must, to be considered minimally conscious, they must demonstrate an ability for some sort of purposeful or functional communication and object use with at least two different objects. Let's see. Okay, so let's talk about some of the stuff on the screen here. In the bottom left-hand corner, that is called a G tube, and that is or a gastronomy tube. And so that is a feeding tube that it goes straight from the outside of the body into the stomach or intestines, and the person is fed through something that looks sort of like an IV, something that looks like formula that you might feed an infant. And so that's a G tube. If the person is not conscious or doesn't have the motor coordination enough to safely swallow or even chew, they often will be given a G tube so they can have nutrition, even though they don't have oral motor capacity. We have talked about shunts. We've talked about intracranial pressure. Another one, and this one, if you watch the HBO coma documentary, you will see this one too. This is in the right-hand corner on the screen, an NG tube. So that stands for nasogastric. And that's one when a small tube is put down the nostril, down the throat, all the way into the stomach. And this might be used for shorter term feeding, but long term, the person would very likely get a G tube just because it's less irritating to their system and less of a chance of infection. We've talked about the ICP monitor. Sometimes when someone is going through the Rancho scale progression, they may become combative and be pulling at tubes and wires that are attached to them and might be needed for their safety or survival. And so sometimes you might see their arms or hands restrained with a soft restraint, and that would generally be for their own safety. You will come across, if you are working with people with severe disorders of consciousness, different protocols. Most often, the medical team will be asked to turn them from side to side every couple of hours around the clock so they don't get too much pressure on their skin. And a trach is the last thing on this list. And let's see if this will show a little something about that. Let me turn that audio off. There we go.
A tracheostomy is a surgical opening in the windpipe or trachea. A tube is placed in the opening, thus the air goes in and out of the tube rather than through the nose, mouth, and throat. Because the nose and throat are bypassed, the air does not get filtered or humidified. This leads to mucus. Here's a picture of how the tracheostomy tube fits in the trachea. A patient would need a tracheostomy for 3 reasons. 1, to bypass an obstructed airway. 2, to clean and remove secretions from the airway. And 3, to effectively and safely deliver oxygen to the lungs. The parts of a trach include the connector, the inner and outer cannula, the neck flange, the cuff, inflation line, cuff port, Luer valve, and obturator. The connector is the outermost portion of the tracheostomy tube. Ventilator tubing, a manual resuscitation bag, or a speaking valve may be connected to the connector. Here's a picture of humidified oxygen being administered through the tracheostomy tube. The neck flange has holes on either side for securing neckties. These neckties will keep the tracheostomy tube in place. The external cannula is the tube that is inserted into your windpipe. It stays there all the time and may have another part called the internal cannula that slides inside of it. The internal cannula is the tube that fits inside your outer tracheostomy tube. It is removed for cleaning or replacement. Lastly is the obturator. It is used as a guide to insert the tracheostomy tube. The inflation line is thin plastic tubing that carries air to and from the cuff. The cuff port is a small plastic balloon-like component on the end of the inflation line. The cuff port shows if the cuff is inflated. The Luer valve is where the syringe is connected to inflate or deflate the cuff. The cuff or the balloon is on the end of the tracheostomy tube. When inflated, it forms a seal against the wall of your windpipe. This stops the airflow through your mouth and nose so that you breathe through the tracheostomy tube. When the cuff is inflated, the patient will be unable to speak. Here's an illustration of how the cuff works. When the cuff is inflated, the patient will only be breathing through the tracheostomy tube. When the cuff is deflated, the patient will be able to breathe through their nose, mouth, and throat. As a nurse, you need to ensure that if the balloon is inflated, the tracheostomy tube is not capped. Otherwise, the patient will have no airway.
All right. So obviously that video was really for nurses or nursing students, but it's important for you to be aware of the different parts of that. I don't think that I knew, even when I got out of OT school, that someone could have a trach and not be on a ventilator. Sometimes they are on a ventilator, and they kind of showed how that would be connected. That's if they're unable to inflate their lungs and deflate to breathe. For different reasons. But sometimes people will just have a trach, and they listed in that video the other reasons or the other functions of that. Sometimes they will just have the tube still there, but they're not on a ventilator. So I wanted to make sure you guys knew that. All right, next scale. This one's called the Disability Rating Scale, or the DRS. And I think if I had to say um, which one of these so far is probably most helpful to somebody in OT, this one's going to be it, of the ones we talked about so far. Really important to note that this one really was developed and tested on older teenagers and adults with moderate to severe TBI. An advantage of the DRS is its ability to track the person from what they call coma to community. So over time, to track their progress. So in that way, it's similar to the Rancho. This one consists of 4 different categories: arousal and awareness, cognitive ability as it relates to self-care, physical dependence on others, and then psychosocial adaptability. So you can see where it's just very OT. The maximum score that somebody can obtain. Now, this is a difference, so pay attention to this one. The higher someone scores, the more severe their status is, their brain injury is, and the more dependent on care that they are. So that's different from those other 3. A higher score indicates more impact or more need for care, and a lower score is less. So the highest or most involved number is a 29. And that indicates, lower performance or lower independence. Somebody without a disability would score a 0. So again, that's different from what we've been talking about. Here's the rest of that scale. So it shows this dependence on others, cognitive ability specifically for self-care. So this is not, you're not asking them to remember words or the things from the slums. You more so are observing, directing or requesting that they do certain things, or sometimes even just positioning equipment or like the toothbrush and that kind of thing in front of them and seeing if they are able to complete that routine with any amount of assistance or independence. All right, so let's keep going talking about the role of OT when someone has a severe disorder of consciousness, whether it's any of those three levels that were on the other slide, going from coma to vegetative state to minimally responsive. What do you do with somebody like that? Well, range of motion. This is a case when we are going to look at prevention of further problems, being shortening of the muscles, fixation of the bones from lack of movement, and also skin integrity problems, or in other words, pressure sores, ulcers that could form on the skin and actually end up going very deep down into the skin that could and often do get severely infected. So range of motion and positioning. And positioning isn't just rotating from side to side. It also, you can see that this person has the pillow on the side of their head to keep their head at midline. And so that is, even the neck would get that range of motion, but also using pillows, towel rolls, and other types of cushioned equipment to position the person so that they are not always staying facing one direction or holding a limb or other body part in one position. It also can be used to minimize the contact that their skin has with the bed or like a wheelchair or other type of chair, like a recliner. Um, Sensory stimulation, I have that one on here with a question mark because there's actually some conflicting literature talking about should we increase the stimulation, intentionally provide stimulation, like different smells, different sounds, like playing music constantly in somebody's room if they are in a disordered consciousness state. When I first entered the field of OT and worked a good bit with children and teenagers who were in disordered conscious states, the literature at that time indicated that we should provide increased stimulation. So, playing music, I even had like a little smell kit that I carried around to different people's rooms, and it would have like some like vanilla and peppermint, and you would put it on a cotton ball and have them smell it, almost like essential oil diffusion. And since then, though, that was 35 years ago. So since then, the literature has more indicated that we would not want to add, certainly not a lot of the time or around the clock, extra sensory stimulation. It just overwhelms that very fragile, recovering nervous system. All right, let me see what time it is. I'm gonna go ahead and play this. This is a personal story, so it's important to connect. To me, 'cause I'm a little unsteady, a little unsteady. Hold, hold, hold on to me, 'cause I'm a little audio down. A little unsteady. I'm here.
Right when you feel like flying, you love me. I'm a little unsteady, a little unsteady.
Like a small boat on the ocean, sending big waves into motion.
All right, I'm going to kind of talk you through some of this. So notice that abnormal posturing of his left hand. Notice how he holds that left hand. So he's very likely got increased muscle tone. So if you went to range that arm, you would notice that it's harder than usual to move that arm, and he in turn would have a much harder time moving that arm. But this kid has had a lot of recovery over 10 years. And so one thing I wanted to say is you will sometimes hear or read that people don't really recover more after about a year after a traumatic brain injury, or sometimes they'll say 2 years. But that is not always the case, especially in a younger person or otherwise healthy person. So you can see this kid, I mean, he was a toddler when he had the brain injury, and now he's continued to get rehab as an outpatient and probably in the schools. And he's able to do a lot of things that increase. Now, that's a hyperbaric oxygen therapy that is supposed to be helpful for neuroplasticity. He's got a splint on in that picture that is keeping his hand from flexing in too much to get contracted. Here they've got him doing some adaptive sports. That's an EEG that they are doing, and all kind of different. See, he uses a feeding tube, but they've got him in different gait training systems. See how that arm still is flexed in? All right. So just a glimpse at what somebody's a short look at what somebody's rehab progression might be. And then I want to talk about what OT might do with people as they are emerging from the beginning or even middle stage of a traumatic brain injury. So, as they are increasing their alertness, awareness, and ability to participate in different rehab services, we want to optimize motor function, always remembering what is meaningful and purposeful and part of somebody's role. But at the same time, looking at improving their strength and endurance to support that occupational performance. Also, balance is another one. We don't want to forget their social, emotional, and behavioral challenges, especially in sort of the middle stage and of recovery. And even sometimes, as was mentioned in the case study presentations, that's something that may persist beyond really the middle stage. It may persist the rest of their life. Executive function problems, impulse control issues. So may need more supervision, even as an adult. Now, this is something I don't think this is in your slides, so you might want to take notes on this. I added this later because it's a term I was just going to talk about it, but I thought, no, I'll add a slide that lists some of the terminology and information here. So you could take a screenshot of this if you want, or just write some of this down. But there's a term you might hear if you are working with people with traumatic brain injury called neurostorming. Now, that even will sometimes be in a medical chart. The real clinical term for that is perioxymal sympathetic hyperactivity, or PSH. And so it really is when somebody's fight or flight system um, gets into overdrive after a traumatic brain injury, and it can be life-threatening um, because their autonomic nervous system that, keeps control of things that are automatic for us, like breathing, blinking, digestion, things that our body does and we don't have to think about it. Even your heart rate, blood pressure, things, and your body temperature. When that autonomic nervous system is thrown into overdrive because of the neuronal injuries in the brain. So it can occur in up to a third of people after a severe traumatic brain injury. And sometimes it's described sort of in street terms as a storm of electrical activity interfering with that autonomic nervous system functioning. Now back to the scales, the measurement scales we've been talking about today. Neurostorming will typically occur again after severe traumatic brain injury. So we're not talking concussion, mild or even moderate, but it will typically see it as the person is starting to become more alert, when their GCS score is either at a 3, but usually at a 4, 5, 6, 7, 8. Primarily in early stages of recovery, so within the first, month or two. The severity and length of time during which this neurostorming or PSH is experienced really relates to the severity of the injury. So the more severe the brain injury, the longer and more severe neurostorming we'll see. Symptoms and what exactly that looks like can vary, but again, it's the autonomic nervous system not functioning typically. So the person's blood pressure may spike and be very high. Their heart rate may be very abnormally high. Often they will run a fever, and the medical team will check out, do they have an infection? But they won't. It's just this autonomic nervous system atypical functioning. They will be sweating. Their breathing will be elevated, not from exertion. And you might see additional muscle tone coming into play in that. So that's what neurostorming looks like. It's different than seizures. And assuming the person continues to progress on the GCS or even the Rancho scale, so they are progressing past a a minimal level of consciousness, that after their recovery is further along, they won't usually experience neurostorming. And so once someone gets out of acute care, goes through inpatient rehab after a traumatic brain injury, especially a moderate or severe one, they then will usually be reintegrated into the community in some way. Now, sometimes, as we've talked about before, they will go to a skilled nursing facility if they are needing round-the-clock care and their medical needs remain great. Too much for the family to handle, or if there isn't a support system in place that can handle their care. But a lot of times they will go home, whether that is to their home or to a family or friend's home. And that would be kind of thought of as the third stage of recovery past acute and then the rehabilitation stage. This is the community reintegration phase. But still, as you just saw in that video with a little boy, they still are working on things that would involve OT involvement. Typically, if there are remaining challenges, cognitive, physical, social, then that would involve relearning different ways to do things or doing things that they used to be able to do, like tying their shoes or walking or feeding themselves. And then sometimes compensatory strategies, adaptive equipment. It's really important that somebody in the in all stages really of after a brain injury have adequate rest. And remember, sometimes their circadian rhythm, their sleep-wake cycle, that's cued by different neurotransmitters in the brain, will be flawed. So they may not get into a deep sleep or may not be able to sleep like they're 7 or 8 hours at night, and they may need frequent rest during the day. So that would be important even if somebody is being seen through home health or outpatient, that they would need breaks to rest. Keeping the environment to the stimulation there to a minimum, instructions direct, maybe starting off giving 1-step instructions, moving into 2 or 3-step, and feedback and redirection when necessary. So let's look at an OT intervention session. Oh, wait, we've seen this one, right? I think so. No, this is, I think, the same guy we've seen before. Let me turn it up.
I'm glad to hear that. You ready to do some work?
Yeah.
All right. Well, today I have brought in some equipment from one of your favorite sports, golf.
Okay, this is the one we've seen with this guy that has left neglect there. So that's, you can tell they're in his home. So that's just an example of what an OT session might look like. Let me get back to that. And before we wrap it up, we're going to play a Kahoot. Yes, thank you, Laura Beth. All right. So as we get logged into this, I'm going to remind you that to prepare for the exam, you can go back through all of the quizzes that you've taken and also all of the Kahoots that we've taken in class or played in class. Link to the course schedule. I have the Kahoot compilation, which I just created a Google Doc and I put the link that takes you to all those Kahoots. So that's a really good way to practice retrieval of that information. When you're studying the assessments that we've talked about, whether it's the slums or the 4 that we've talked about today, focus on what specifically is being measured by that scale, and then what is the lowest, a midway, and the highest level of performance. What does that look like in functional terms? Okay, Casey says the third Kahoot link isn't working, so I'll check that. All right, if you would log in, we've got almost everybody. This is also on that list, but we're going to play it so we can talk about it. Which neurotransmitter is involved in heightened pain sensitivity and some psychiatric disorders like anxiety and depression? What are we talking about here? Good. Most people got it. Substance P. Keyword there really is pain. Which cranial nerve sends messages from the brain to the heart, lungs, and abdominal organs to help regulate bodily function? Good. Most people got it. That is the vagus nerve. You've seen that on several questions. That is an important one. And if you want more help with helping to remember or understand the cranial nerves, OT Mary has a video on that on her site. What's something you should never do when someone is having a seizure? Good. Most people got it. So a little bit of a tricky question because it's not asking what you should do, it's asking what you should never do. Now, some people or one person might have said call 911 because we talked about last week how that's not always indicated or appropriate, but it would sometimes be. So we're not going to classify that as never. Question about the cranial nerve questions on the exam. Yes, they will only have the Roman numerals, but also the name. And the reason for the Roman numerals, remember I told you about that the first time I taught this course, this one student that said she just could not remember Roman numerals and had never learned them. But that is how cranial nerves are represented. So I will say the number in Roman numerals and the name of it. So if you hate Roman numerals, just pay attention to the name of it. What term describes the condition in which a blood clot is on the brain's surface due to stretching or tearing of the vessels there? Yeah, that's a subdural hematoma. It's on the surface of the brain there. We talked about that in a couple class sessions last week. What widely used neurological scale records the level of consciousness following brain injury via the indicators shown? Eye response, motor response, verbal response, and then in some cases on one version, pupil response. Yeah, most people remembered that. So that's the GCS. What device implanted in the brain drains excess fluid away to address buildup of that fluid and minimize the seizure risk? What is that? Yes, that is a shunt, that very, very thin tube that goes from the ventricles in the brain down into the body, usually the peritoneal space, to drain that extra cerebrospinal fluid. Which neurotest tracks an individual's function from coma to community in areas of impairment, disability, and handicap? A couple keywords here. That's a disability rating scale. So notice those keywords, coma to community and disability, looking really, really at function. So that scale is used a lot in OT. Which neurotest has 10 levels of recovery to help decide when a patient is ready for rehab after an acquired brain injury? Yeah, that's the Rancho. That Rancho has 10, and like the cranial nerves, they use Roman numerals for that. What type of abnormal posturing involves the legs held in extension, upper extremities in flexion, and shoulders in internal rotation? Remember the trick I said? All right, so you're going to remember it now if you didn't. When things are curled in, flexed towards the core, that's decorticate. When they are extended, the upper and lower, that's decerebrate with all the E's, like extended. What term refers to the dangerous fight or flight syndrome occurring in about up to a third of people after severe traumatic brain injury? Good. Almost everybody got it. That's the neurostorming. When that autonomic nervous system is in overdrive. And here we go. Here's our podium. All right. And here's everybody. All right. Any questions about that or anything else we talked about today? Or
I just had a
anytime?
question. Sorry.
Yeah.
I just had a question about like the kid that had the traumatic brain injury.
Mhm.
He seemed to have like a lot of like regressions over time. Is it more common to see like regressions in kids since they're getting older and having new developments? That wouldn't be typical. Because I feel like with
I think it was
adults,
just the way that that video was edited, the exact moments in
okay.
time that it showed, because it's not really common. The main thing that you might see regression in is if they weren't continuing to get rehab services or and somebody wasn't, using the splint or the correct positioning or range of motion, if their activity level decreased and they weren't getting the appropriate stimulation, you might see regression there. I think it was just the way that was edited. Yeah. Anybody else?
Thank you.
Thanks, Larbeth. All right. So, a little reminder that you have to have Respondus before 10 o'clock on Wednesday, and we will take that exam whether we're doing it virtually or in class. We'll just watch for what UT tells us about coming to campus, and watch that for your other courses. And I think your community observation for tomorrow is probably going to be canceled for that safety reasons too. But in the meantime, if you have questions or need support, you know how to reach me. Thanks, everybody. And I'm going to post this recording if just in case later this afternoon, as soon as I can upload it to my YouTube. All right. See y'all Wednesday.